So first of all, thank you for taking the time to listen to this seminar, and also thank you to Datum for hosting us and allowing us to communicate regarding this issue. This evening, I'm going to try and share with you a bit of our knowledge regarding aesthetics following bone augmentation in complex cases in the anterior maxilla. So if we're trying to look at the final aesthetic result in implant dentistry, it will be dictated by several variables. It will be dictated by surgical variables, prosthetic variables, and of course, by soft tissue support. The main essence of this presentation is soft tissue support and how can we contribute to improve it. So in order to deal with the subject, we need objective tools. And one of these objective tools was developed in 2005 by the group of George Watzek, by Rudolf Furhauser and his colleagues. And he introduced the pink aesthetic score, which included 7 variables, which could be scored from 0 to 2. In 2009, Belzer and Bruiser, they actually introduced a modification. They called it the modified pink aesthetic score, which basically included only 5 variables, and added to it the white aesthetic score, basically introducing the modified Best-West score, which is very popular today in many studies. In this score, the parameters are tested in comparison to the homologous tooth. And if you want to look at the parameters that are being tested, it is the mesial papilla, the distal papilla, the curvature contour of the buccal gingiva, the height of the buccal gingiva, and the curvature of the root color and the texture of the soft tissues and the buccal aspect of the implant site. And if we look at the mesial and distal papilla, we're scoring it 0 when it is absent, 1 when it is incomplete, and 2 when it is complete. If we're looking at the other 3 parameters, we're scoring 0 if there is a major discrepancy, 1 if there is a minor discrepancy, and 2 if there is no discrepancy. So actually the maximum score is 10. You'll see later that the West also the maximum score is 10, so the maximum score will be 20 together.
I'm sorry, Professor Chaushu, for interrupting.
Yes.
We do not see any changes in slides.
Now you see the first slide still?
We still see the first slide. Maybe clicking page down.
Now you
right.
see.
Now we see the. Yeah. Now we see the change.
Now you see the slide?
Yes, sir.
Okay.
All right. Thank you.
So yeah, we will try to use this format. I don't know why I did, but we'll try to use this format. Okay. So should we show the previous slides or we can continue? Let's continue. We will, if there are really any questions, we can explain it later. If we look at the literature, there are 2 classical articles concerning aesthetics. This one comes from Belzer and Bruiser, 2004, trying to describe what will determine the facial aesthetics. And basically, there are 2 issues that will give you the best aesthetics. One is the height of the alveolar crest of the adjacent teeth, and 2 is the height and thickness of the facial buccal wall. So as you see here, the height of the crest and the thickness of the buccal wall. Well, basically, the crest, the level of the crest of adjacent teeth is something that we do not actually control, but we actually get the situation and we have to deal with it. Whereas the buccal thickness and height, we can control and we can affect. Another classical study comes from Grunder in 2005 demonstrating the same basic principles and stating that we need at least 2, preferably 4 millimeter buccal to the implant in order to have a stable aesthetic result a long time. So the issue is the buccal bone thickness. And when you look at the buccal bone thickness, it may affect a variety of issues. It may affect the vertical and horizontal bone resorption, which is followed, of course, by recession, which will affect finally the soft tissue aesthetic and the implant survivability. And if we actually down a minimum threshold, it can help us determine in what cases we need to perform augmentation. KOLs and the literature try to define 2 millimeter as this threshold, but the question is whether this threshold is actually evidence-based. And the reason that we need this thickness is vascularity. The hypothesis is that thin fascial bone is more susceptible to resorption due to decreased vascular supply. So that's why we need some thickness to keep this bone alive a long time. If we try to look at database articles that we have, this is actually the only and most extensive study that exists in the literature. It was published already in the year of 2000 by Spray and colleagues. They tried to find the correlation between the fascial bone thickness and vertical bone loss a long time. So they measured the fascial bone height as a function of fascial bone thickness between implant placement and implant uncovering. And what they found in this study was that actually we have a curve that gets to a plateau at the values of 1.8 to 2 millimeters. And when we reach those values, we do not have any more bone resorption, and sometimes we even have bone gain. When we have less bone thickness, as you see here, we can reach a vertical bone resorption that may reach even 3 millimeters of bone loss, which is extremely important from an aesthetic point of view. And another factor that we try to consider is bone density. And we want to know whether bone density can influence the final result. And as you see in this study, different bone qualities from 1 to 4, actually there was no influence of bone density on vertical bone loss. So it could be very nice if this was the only study, or if all the studies would be the same. But you know, as it is always, it is much more complicated. And this is a review that was published in 2021. And in this review, they try to collect all the relevant articles that will demonstrate what is the significance of fascial bone thickness concerning recession and resorption. So they collected several studies that answer the criteria. You see this Spray study over here. It is the most extensive, around 3,000 implants, and it's very difficult to compare it to the other studies, which the numbers are basically much lower. And what they could find in those studies was that basically there was a wide range of fascial bone thickness from 0.5 to 1.8. And despite this high variety, there was always a high survival rate of the implants. One of the drawbacks is that most of the studies are short-term, and their conclusion was that based on short-term data, there does not appear to be a relationship between implant survivor and buccal bone thickness. So we thought it is simple. We thought the more bone we have a better result. But this is not really so conclusive when you look at additional articles. And what you see here, that survival was not worse, and even resorption was not worse. So again, no relationship nor to implant survival, and nor to vertical height. So their conclusion was that buccal thickness, even of 0.5, yields a high survival rate, 97 to 100. However, we still need long-term follow-up. And soft tissue changes will occur anyway after implantation, around 0.5 millimeters, and there was no threshold of minimum buccal bone thickness that will avoid soft tissue recession. So basically, the statements of Grunder were not actually confirmed by data. It was more like a feeling of a very important KOL, but no data supported it. And of course, we still need prospective studies to demonstrate this relationship, this importance, if at all. Another view that was published 1 year earlier in IJOMI tried again to review the same issue, the influence of fascial bone thickness, of course, about remodeling of fascial bone, soft tissue recession. And again, their conclusion was quite similar. No minimum fascial bone thickness was seen that would completely avoid peri-implant bone loss and maintain soft tissue stability. However, their impression was that a thickness of approximately 2 millimeters can be associated with diminished vertical bone resorption and less peri-implant mucosal recession. What about buccal bone density? This study from 2010 stated that in short-term perspective of 1 year, there is no difference in survival rates or changes in marginal bone level between implants placed in bone tissue at different density. So again, density, no importance. Let's look at newer studies from 2022. Implant areas with higher bone thickness and density had less bone loss. So again, contradictory results. Another more recent study, less bone loss was observed in implant areas with higher bone quality. So actually, we cannot say for sure that increased bone thickness and increased bone density will definitely give us a better aesthetic result. But definitely, most of the clinicians will like to have at least 2 to 4 millimeters buccal to the implant. Of course, it is not an absolute demand, but a preferable demand. So let us share with you how we deal with complex defects in the anterior maxilla. It is much easier when we have a containing defect. Look at this case. This is a trauma case. The difficult situation here, the difficult challenge is that we have a diastema. Now, if we fail, we cannot make a bridge because then we have to have a very long bridge because this diastema has to be divided among many teeth. So actually, we need to place a single implant, and the single implant in the aesthetic zone is a very challenging issue. Now, when we look at the preoperative periapical radiograph, we can see the horizontal fracture from this trauma. And when we look at the preoperative CT, we can see the buccal bone is actually missing. So if we said before the buccal bone is one of the most important things, we need to get this buccal bone before we can continue. So we are very brave and managed tooth extraction without raising a flap. But when we actually felt the buccal bone dehiscence, we decided to raise a minimal flap. And here you can see actually the buccal defect. What we're using in most of the cases is mineralized freeze-dried bone allograft. We fill this containing defect with mineralized freeze-dried bone allograft, and we always cover it with O6 because O6 will allow us to maintain the bone volume, increase our new bone formation, and increase our ossification. And of course, you need to do a tension-free closure because otherwise all the bone graft will be lost. So this is actually how we started. This is the clinical view at second stage surgery. Now you can see the bone gains that we have from this defect to this result. Now it's perfect. Now we can place our implant, have enough buccal bone, and continue for a successful result. In this case, we did immediate aesthetic restoration. As you can see here, because we are in Israel, so God was with us, and you see the occlusion, which is favorable. Otherwise, it would have been more difficult to do the immediate aesthetic restoration. And this is the final result, which is quite nice. And it was very challenging because a failure here would have been a problem. But this is more important. Look at the same case 10 years afterwards. We have here a little bit of marginal bone resorption, but it is completely acceptable for a 10-year case. If you look at the clinical view, it's really very nice. So what is the most important issue? To have the stable result of the single implant in the anterior zone. So in order to have that, you need to have this bone. I know it is not completely evidence-based, but dentistry is not a 100% evidence-based profession. Let's look at another case. This is a Maryland bridge. When I was a student 30 years ago, we were taught that Maryland bridges are good only in Maryland. But since then, many things advanced, and today Maryland bridges are very good, very qualitative, and can cope with time. But still, this patient wanted to have an implant over here. She didn't like the bony defect on the buccal, and she really had to had several times bonding of this Maryland bridge, so she preferred an implant. When we go to the preoperative CT, we see actually that the bone thickness is very minimal, and actually this doesn't look like a containing defect, but rather like a no wall defect, which would be more complicated to feel three-dimensionally. But if you look at the clinical view, you can see that because of this concavity, we have the roots of the central and the canine that actually create like a containing defect. So, although we had minimal bone, we managed to place our implant, we cover it with particles, and we placed a double layer O6 over the particles. The double layer will not give you much. It will just give you support. If you place one layer, it's okay. If you do a double layer, it's mainly to support the first layer, no more than that. But we use this technique in many cases to have better stability. So we did soft tissue scoring, and unfortunately we had a fenestration, as you see here. We were annoyed a little bit initially, but this is the implant in place. But after 8 weeks, and as you see here, a lot of chlorhexidine rinses, we had a nice situation. It healed, a small scar, but it was not extremely significant. After 4 months, you can see the nice situation, the nice bone volume gain buccally. And when we opened, we were very enthusiastic to see the ossification of the O6 membrane over the implant. You can see here we have enough buccal bone, and you can see here's ossification. We had actually to remove this bone in order to gain access to the implant. Well, going back to the literature, we're not the only one to see that. You see here 3 studies that demonstrated this ossification in dogs, in humans, and eventually led to the development of Volumax and O6 bone. but this is one of the good qualities of the osseous membrane. It can be ossified if you leave it long enough, and it will help you gain more new bone formation and more ossified bone inside your bone graft. So implant exposure, as you see here, healing cap, and final result. You can compare the buccal contour of this lateral to this lateral. Again, we managed to gain a nice bone volume buccal to this implant. But when we don't have a wall, a no-wall defect is much more complicated situation. So in this situation, we actually like to use blocks, and we use cancellous block allografts because we believe that those cancellous blocks will have a faster resorption, will have a faster new bone formation, new bone infiltration, and we use always the osseous membrane to protect this block from resorption. So because we don't have a cortex, the osseous membrane takes place of this cortex and allow us faster ossification and prevents the resorption. So of course we performed already more than 20 publications we published on this issue, but let's try to concentrate this time on the publications that we did in the anterior maxilla. The first study that was published already in 2009 dealt with the clinical evaluation and clinical results of using cancellous bones covered by osseous in the anterior maxilla. Now let's see how we do it actually. Okay, now let's see the result that we gained.
Don't touch turbo boost. Something tells me you shouldn't touch turbo boost.
Okay, so what is important to see that the fact that the O6 membrane lasts allows us very good protection, minimum bone resorption, and you could notice the bone density. So there are several studies that demonstrate that when you cover your blocks with membrane and chips, you gain less bone resorption. And of course, the O6 has a big advantage because it lasts longer than other membranes. And because of this longevity, it will allow you a much better result. Let's look at some other cases. Again, a missing lateral orthodontic treatment, block preparation, block fixation. We always aim to achieve at least 8 millimeter in order to have at least 2 millimeter buccal to the implant, considering that most of the implants have a diameter of 4 millimeter. Again, double layer, which is not mandatory, but you can use it. In this case, you can see again the power of the O6 because we didn't even use particles. We just use space maintenance of the O6. And after 9 months, in this case, we had to open after 9 months because of the orthodontic treatment. You can see the bone gain even in areas that did not have bone graft. Just simple space maintenance that was provided by the membrane. Again, here, immediate aesthetic restoration and aesthetic abutment with crown. And look at the final result. Look here at the buccal bone. We have a very nice bone volume. And if you try to compare this lateral to this lateral, I think that if you do not know in advance that this lateral was missing, it will be very difficult to differentiate between the two. And again, stability 24 months after. We have a little bit of gingivitis here, but again, it's a stable result. Let's go for the last case that I'm going to present. Again, a challenging case, trauma case. The right central was lost. The left central has internal and external resorption. You can see here the thickness of the buccal bone. This was a temporary restoration after removal, the clinical view. And this is a bony defect. So we wanted to do augmentation, but we wanted still to keep the temporary restoration. And we wanted to perform immediate implantation, but you wanted to have enough buccal bone when you do this immediate implantation. So we did a little trick here. We used the block on the missing tooth, but we did buccal augmentation on both centrals in order to gain bone buccal to the left central. And of course, we covered it with O6. Tension-free closure. And you can see here, after 6 months, 0 bone resorption. And here you can notice the ossification of the O6 membrane. And again, after extraction, look at the ossification of the membrane and look how much buccal plate thickness we have here. So in these cases, it is very safe to do immediate implantation. 2 MIS implants were placed. This is 7 coming from MIS. Again, to be sure, we did another bone augmentation, basically to preserve our result. Again, coverage with O6. We're human. We forgot one screw here, but we took it later. And the temporary restoration always needs not to rely on the anterior teeth. This is soft tissue healing. Second stage surgery. Look at the amount of buccal bone that we have on those 2 implants. This is how we started. This is the buccal bone that we have. And of course, we remove the screw. And this is the final restoration. And look at the buccal bone profile. So clinically, we wanted to evaluate the results of bone block allograft covered with O6. We had 31 patients. You saw the bone deficiency, 46 blocks, always covered with O6, healing 6 months, 63 implants, most of them MIS. We measured before bone augmentation, during implant placements, and second stage surgery. Our mean follow-up was 34 months. And you can see here that our mean horizontal gain was 5 millimeters. Our mean vertical gain was 2 millimeters. Resorption was minimal, 0.5 up to implant placement and 0.2 up to second stage surgery. And we always achieved more than 2 millimeter buccal to the implant. So there was no evidence of vertical bone loss between implant placement and second stage surgery. Block and implant survival rates were high, 95 and 98, and all patients received a fixed implant supported prosthesis. Our conclusion, of course, was the cancellous block allograft covered by O6 appeared to hold promises for grafting the anterior maxilla. This was in 2009. Today, we are sure of this conclusion. Of course, the next stage was to do histomorphometry because it was not enough to succeed clinically. You also want to see histomorphometrically if you have new bone. And of course, when we checked the results, newly formed bone was 33%, residual cancellous block was 26%. The biopsies were taken during implant placement. Marrow and connective tissue, we had 41. So this is after 4 months. This will continue remodeling afterwards, and of course, we'll gain more new formed bone and less cancellous bone. But for 4 months, this was the result. And an interesting finding was that newly formed bone was much higher in the younger, and residual cancellous graft was much lower in the younger. Marrow and connective tissue was basically the same. And the reason for this higher rate of new bone formation in younger is, of course, the number of human mesenchymal stem cells that we have. When we are born, it is 1 to 10,000. When we are over 80, it is 1 to 2 million. So actually, we have less mesenchymal cells that will help us in new bone formation. So our conclusion from this histomorphometric study was that cancellous bone allograft covered by O6 will allow new bone formation, and that this new bone formation is, of course, age dependent. Now, let's go to the last study that I promised you, and this is the white aesthetic score. I'm not a prosthodontist, so I'm not going to relate too much about it. Those are the things that we score. Again, homologous tooth, major discrepancy 0, minor discrepancy 1, no discrepancy 2. maximum score 10. And this is the studies that we published in JCM in 2021. Again, after seeing that we can reach long-term predictability, after seeing that we do have new bone formation, the last step was to see whether we can also reach aesthetic result of this kind of treatment protocol. So again, inclusion criteria, as you see before, nothing special about it. Exclusion, like in most studies that you will see. Method, modified PES-West, 33 individuals, once a year radiological, clinical, and photographic follow-up. 10 men, 23 women, average age 40, average follow-up 62 months, which is quite nice. Etiologies for bone deficiency, periodontal, trauma, and congenitally missing teeth. And those are the results of the entire group. You can, of course, open the article if you want to see all the results. We know that the total minimum threshold for a clinically acceptable result is 12. And as you see in this table, there were no patients that presented modified PES-West, which was lower than 12. If we look at the PES, the minimum acceptable is 6. The average was very high, 9. If we look at the West, again, the mean was also very high, 8.8. And if you combine them, again, a very high score, 17.8. So our conclusion was that the use of cancellous bone block allograft covered by O6 and late loading permits a predictable aesthetic result and stability of the peri-implant soft and hard tissue over time. So I'd like to thank my colleagues, Dr. Chaushu, which is also my wife, Dr. Shaked Mizraki, which is a student that did the study, and Professor Joseph Nissan, which is my colleague for the last 20 years. He's a prosthodontics, and he's doing all the prosthodontics that you saw in this presentation. And I'd like to thank you very much for your time and your attention. And if you want to contact me, you can contact me by either this phone or this mail. And of course, thanks Datum and Dentsply for organizing this presentation.
All right, thank you very much.
We can go to questions if you want.
Yeah, so thank you very much, Professor, for a great lecture and very fascinating cases. There is one question waiting for you. I will read it to you out loud for you in the audience, but in the meantime, with your permission, I would like to share my screen for a second.
Okay.
Right, so first of all, again, thank you, Professor. I would like to ask the audience to fill out our feedback survey for this webinar. By the way, there is a poll for everybody, so please also along with my speaking, you can be more than welcome to answer for this poll as well. So please, everybody, if you can have 2 minutes to dedicate for applying this feedback survey, it's crucial for us for our future improvement. We highly appreciate your feedback. So thank you so very much for this one. And I would also like to inform everybody of our next event. So we have next month on May 10, and we have Dr. Matty Fine and Dr. John Kim for clinical discussion. A week afterwards, we have Dr. Angela Palayoglou. I hope, sorry for maybe I didn't read correctly. And in June, we have Dr. Sasha Tograner. You can register from here, and you can also register those events from our webinar, from our educational page. Also, I'd like to inform everybody for the biggest conference, which coming up in June, the Implant Solution World Summit, which this year will take place in Athens, Greece. Aside of lots of lectures, great speakers, there will be a masterclass, a social event, networking, and many other wonderful activities. Of course, there will be lots of talking about region in multiple events, like the region battle sessions, hands-on master classes, and much more. For more information, feel free to scan the QR code at the bottom of the screen over here to get more information. And of course, we'll be happy to see you all there. Just a second. All right. So here's again the feedback survey. We'll really appreciate if you can scan it. There's one, Professor, there is one question for you. We saw beautiful cases which basically you took to the extreme. And we saw in one time you used one layer of O6 plus. In one specific case, you used double layer. So what are the the fingertips of the handling, or how do you recommend people to use the O6 plus?
Well, basically, it is not important. You can use O6 plus either as one layer or a double layer. The double layer is not necessarily going to improve your results. If you want to improve your stability, you can use the double layer, but the single layer will give you a good result as well. It's not really nearly so important, the difference between the two.
Do you need to tuck it? Do you need to suture through it? How is the handling process over there?
Well, you need to do a very simple thing. You just need to take a gauze. First of all, it has to be wet, because otherwise you can not use the O6 plus. It's not like other membranes that you need to use dry. The O6 plus, you need to wet it first. And then if you want to have stabilization, you just do a simple thing. You press it for a few seconds with the gauze, with the wet gauze. And believe me, you'll gain very nice stability of the membrane.
All right. I see no other questions. By the way, any tips for using this membrane for first time? For first-time
Sorry?
users? Any tips for first-time users for using this membrane?
For first-time users, yes, the two tips. First is always try to start with the smaller membranes. It will give you easier manipulation. If you have a big area, do not use one big membrane. Use several smaller ones, or if you have a big one, cut it into smaller parts. It will give you better adaptation than trying to use a huge membrane over a huge area. Several small parts will give you better adaptation. And again, wet it first, and after you know where to put it, light pressure with the gauze, and it will be stable.
All right. Thank you so very much, Professor, for a great lecture. Thank you, everybody, for joining us today. That was the last question, so thank you so very much. Everybody, thank you so very much. We hope to see you all in our next event. Have a great day, evening, wherever you are. Thank you for joining us. Thank you, Professor.
Thank you very much.